Now we would like to welcome Dr. Alaniz, who is the gynecologist of our team and who will give us a talk. Thank you, Dr. Alaniz.
Hi, everyone. Thank you for having me. I'm going to share my screen, so just give me a minute. So I'm the gynecologist on the team, and I am going to be talking about gynecologic concerns among girls, teens, and young women with anorectal malformations. And these gynecologic concerns really arise during all stages of life. So we see gynecologic concerns during infancy, during puberty, with sexual intimacy, and then fertility and obstetrics. It's really important to evaluate the gynecologic anatomy, and we can do this at various times before a definitive reconstructive surgery with preoperative imaging like the cloacogram or an MRI, at the time of primary repair with an exam under anesthesia or a vaginoscopy, which is placing a small camera inside the vagina to visualize the vagina and then cervix or cervices. And then with any abdominal surgery where an open incision is needed, we can take that opportunity to evaluate the reproductive structures internally. So evaluating for the presence of a uterus or two uteri, the fallopian tubes, and the ovaries. We know that uterine anomalies are common in patients with anorectal malformations. So the most common are uterine duplication with sorry, my screen is blocked. Give me 1 minute. Okay, so uterine duplication is the most common in about 34% of patients. And we see this most commonly in patients with cloaca. Up to 60% will have a didelphys uterus, meaning two uteri or uterine duplication. The other common uterine anomaly that we see in anorectal malformations is vaginal agenesis. So the vagina and the Müllerian structures, the uterus, are underdeveloped. And this happens in about 5.5% of patients with anorectal malformation. So with uterine and vaginal duplication, this really has no implications in childhood, but during adolescence and adulthood, the longitudinal vaginal septum, that tissue that's dividing the vagina in half, can impact sexual function and menstrual hygiene. So there can be difficulty with penetrative vaginal intercourse. And then if that septum is still left in place, if a teen or a young woman is trying to use a tampon, it can either be painful or they can have leakage of menstrual blood around the septum if the tampon is just on one side. And then the duplicated uterus or the didelphys uterus can be associated with pregnancy complications, specifically intrauterine growth restrictions, so small babies, preterm labor, preterm birth, malpresentation, meaning the baby will be butt first instead of head down, and then need for C-section. So the majority of patients who have vaginal agenesis will have complete agenesis, so absent uterus and vagina. Some will have partial vaginal agenesis, meaning only the lower half of the vagina did not develop. So during the posterior sagittal anorectaloplasty, vaginal replacement may be indicated. And if there are several options for this. So if this sacral ratio indicates a poor prognosis for bowel control, then rectum may be considered for vaginal replacement. But if the patient is expected to have good bowel control, then usually descending colon is used as a graft for vaginal replacement. So I'm going to talk specifically about some of the gynecologic concerns during infancy. The most significant gynecologic concern is hydrokopos, which is distension of the vagina with fluid, urine, and or mucus. And the treatment is draining that fluid collection, usually with a vaginostomy, which is a tube that's inserted into the vagina to drain that fluid until the patient has definitive surgical repair. The other thing is the vaginal septum. So if a patient has a duplicated vagina or that septum, longitudinal vaginal septum, that can be taken down during the reconstructive surgery. In terms of puberty, pubertal development in girls with anorectal malformation occurs as expected. We know that effective menstruation requires adequate uterine development, an endometrium, and then a patent vaginal outflow tract. We do see some menstrual concerns in patients with anal rectum malformations. We can see absent periods from underdeveloped uterine structures, which happens in about 20 to 30% of patients. We can also see obstruction of menstrual flow, so that's trapped menses, in about 30 to 40% of patients. And that can occur from scarring, or if there was a didelphys uterus that was where one uterine horn wasn't recognized during the original surgery, as you can see down in this bottom picture, and not incorporated into the repair. Puberty is especially an important time to assess the reproductive structures. And we do this with a variety of methods. So we may use ultrasound or MRI, vaginoscopy to really evaluate the vagina. If the patient is undergoing an abdominal surgery, we'll use that opportunity to check the fallopian tubes for patency, make sure that they're open, and then examination of the vaginal opening either in the operating room or if a patient allows in the clinic setting. As the gynecologist, I may discuss hormonal suppression of periods. And this is for a variety of reasons. If there's any concern for trapped menstrual blood or obstructed menstruation, then we want to stop any further periods with hormonal therapy. We can also consider hormonal therapy for other routine gynecologic concerns. So dysmenorrhea, painful periods, if your daughter has heavy menstrual bleeding, or if there are any hygiene concerns, if periods are heavy and it's difficult to manage those periods, we can make them lighter or make them go away with hormonal therapy. Specifically with menstrual obstruction, the treatment options preoperatively include menstrual suppression, so stopping those periods. If the obstruction is significant, we may recommend draining that with our colleagues in interventional radiology, or placing a vaginostomy tube to drain the obstructed menses. The definitive surgical management for menstrual obstruction is, depending on the situation, vaginoplasty if there's concern for scarring in the vagina. If there's a septum that's blocking the outflow of menses, then resecting that septum. And in very, very rare cases, when a vaginoplasty or septum resection is not the best option, removing the uterus. So sexual function is complex and really dependent on many factors: a woman's anatomy, relationship status, other medical comorbidities, so fecal urinary incontinence, spinal cord anomalies, adhesive disease. These can all affect sexual function, and of course, psychosocial factors as well. We definitely recommend evaluate if a female with an anal rectal malformation has had surgery on the vagina. We recommend evaluating that vagina prior to engaging in any sort of sexual activity. If there is scarring present, that may need treatment, either with dilation, so gently stretching out that scar tissue, and in some cases, surgery, which is usually a minor outpatient procedure just to relieve some of the scar tissue at the opening to the vagina. And then with reproduction, we know that spontaneous conception is possible, although assisted reproductive technology may be needed in patients who have a history of a more complex anomaly or who had a complex reconstructive surgery. Certainly, I recommend preconception counseling for all patients that are wanting to get pregnant because comorbidities are common, uterine anomalies are common, and then most patients have a complicated surgical history. And then in our patients that do get pregnant, the mode of delivery really depends on the type of anal rectal malformation. And then I'll take any questions in the chat box. Thank you.